My name is Abi Siva. I'm one of the breast medical oncologists at the Medical University of South Carolina.
My name is Dr. Carey Anders, and I'm a breast medical oncologist at the Duke Cancer Institute.
Hi, Carey. It's so nice to have you here, and we are here to discuss some of the upcoming data around DB05 and DB11. And there are some interesting questions and practical questions that our academic oncologists, as well as our community oncologists, are battling with in terms of choosing the right patient population for the right situation to use Enhertu. I thought I just wanted to get your thoughts on how do you interpret the data, and where do you see the utilization of Enhertu in the HER2-positive early-stage setting?
I could not agree more. It's been a very exciting ASCO. We've learned a lot. I think much of the data has been very confirmatory for what we've known about earlier this year, which continues to build our confidence in how we're making decisions. I think sort of starting in the neoadjuvant space with DB11, we are seeing higher pathologic complete response rates in the neoadjuvant space. It's interesting in terms of how to sequence the TDXD and the taxane trastuzumab pertuzumab. I know that's one of the questions we've been thinking about and would love to hear your thoughts as well, compared to the comparator arm, which is a little different than what I think we traditionally give in the United States. I think traditionally I would give a taxane, platinum, trastuzumab, pertuzumab, compared to the control arm, which was an anthracycline-containing arm. And then, of course, there was an arm that was the TDXD alone, 8 cycles, which was stopped early due to not wanting to move forward based on activity. So having these 3 arms, really the 2 arms to compare, of course, the pathologic complete response rates were higher in the TDXD THP arm. And when I think back historically, one of the things that I really want my patients to achieve is a pathologic complete response. We have decades of data saying that achieving a pathologic complete response does confer a better outcome. So, I don't know that we're at a one-size-fits-all in breast medical oncology across the board anymore. But for patients who are coming in with higher burden disease, we have overall their performance status is very good. And we want to really bring them to pathologic complete response. I think we are in a place now where TDXD is part of our neoadjuvant regimen.
Right.
Yeah.
And also the advantage of having only 4 cycles of TDXD with much less rates of ILD it's an attractive strategy to utilize than thinking about using it in the post-neoadjuvant setting if the patient has residual disease, where we are facing 14 cycles with much higher rates of ILD. So that's a concern as well. And that's also another reason to consider using it up front to get the best response we can and get the high rates of PCR so that our patients don't have to face the residual disease scenario.
Could not agree more. I mean, I think the biggest trade-off for TDXD across all of our stages is the concern for ILD, interstitial lung disease. And I think we've gotten a lot better as a breast medical oncology community about how to monitor our patients and recognize it early and try to determine a grade 1 over a grade 2 where we have permanent discontinuation. But I do agree, having the 4 cycles as opposed to 14 does show lower rates of ILD, which is very attractive. And I think in most cases, and I'd be curious to hear what you do at your institution, we have been incorporating an every 6-week non-contrasted CT of the chest during the course of TDXD in the curative intent setting. And in the first year in the metastatic setting, and we'll talk a little bit about that. But I'm curious what you do at your institution and what barriers you might have seen in trying to maintain that very strict ILD monitoring.
Right. I think that's going to be an ongoing problem, especially in the community settings where they may not be able to get frequent scans and insurance barriers. Those could become more of a practical challenges as we start to implement this data in our real world situation. At our institution, there's a little bit of a varying practice between different providers. Some do every 6 weeks, some do every 9 weeks. First, when we had the Enhertu metastatic studies, that was one of the top questions patients. But I think now most of them are agreeing in the every 9 weeks in the metastatic setting. But in the early stage, I think we have to be even more cautious because, again, these are patients. We are curing them from disease. We do not want to leave them with a highly morbid condition like ILD. So I have been advising, and in my practice myself, is planning to utilize exactly the algorithm that was followed on the trial so we can mirror the exact results.
Absolutely, and making certain that we're picking patients that have lower risk for ILD. Yeah. They don't have pre-existing pulmonary conditions, which, of course, in a clinical trial setting is very, we have very strict inclusion-exclusion criteria. But in the real world, not every patient has that exact same health comorbidity moving into the therapy. So completely agree. I mean, I think ideally, I would want a CT scan at 6 weeks to move into the second 2 cycles before surgery. Before surgery.
Yeah. And also, I think, as we are monitoring these patients, like if you detect ILD early on, then in the future, if the patient needs Enhertu for some reason, at least you can go back and use it if it was detected at a grade 1 level. I think it's also more important when we use it for the 1-year duration that we are going to talk about in the adjuvant setting. If you detect it as a grade 1 ILD, then there is a chance that you can go back and use it. Whereas if you detect it by symptoms, we are not able to utilize Enhertu anymore. So I think that's, again, why the emphasis on doing CT scans than waiting for symptoms to happen and then picking it up may not be an advantageous for our patients.
Could not agree more, right? Because if we have patients that are detected at grade 2, one, they have higher steroids, longer duration of steroids, which presents other problems and risks to the patient. But then when we're thinking about their care down the road, whether or not it's adjuvant or metastatic, we're limited. We're much more limited. Could not agree more.
Yeah. That's true. Let's talk a little bit about the patient selection. I think that's where a lot of us are struggling. Where do we think we can still utilize the old school chemotherapy? For example, our US favorite regimen is TCHP, and the NeoCARP study, and there are also German studies showing that even taxane with HP can even be sufficient. We were even questioning the role of carboplatin with some recent studies, but now we are talking about TDXD with the taxanes. We are now adding more options. So, how do we tailor that? Where do we give chemotherapy alone and maybe spare Enhertu for later if necessary? And where do we think it's crucial to bring in the best regimen right away? Like, how do you factor the patient characteristics to make that decision? Do you have an algorithm in mind?
Yeah, I think this is more the art of medicine. Yes. You and I have discussed. I think that when I'm considering, and in the study, of course, the TDXD was prior to the THP. And many regimens in clinical trials now, prior to DB11, have included THP with this question of the platinum, how much benefit are patients deriving from a platinum. So, I think if I have a patient with pretty significant tumor size, multi-lymph node positive, overall healthy, limited comorbidities, I would have a balanced discussion with them to start TDXD first, just like in DB11. If I have someone who has maybe just over the T2, the lymph node involvement is lower in the axilla, they may have a comorbidity, I might consider THP first and then image mid-cycle or mid-regimen to determine whether or not I should complete out with THP or move into TDXD. But then that gives you a little more flexibility and tailoring to that individual patient. The other piece of that would be the hormone receptor status.
Right.
And whether or not, we really want to get the most optimal response for the individual patient based on ER status, positive or negative.
Right. Right. I think, I go through a very similar algorithm too. Like, I think disease burden is definitely going to dictate how aggressive we want to be. And I agree, like, if the patient has high disease burden, then it's reassuring to even tell the patient, I'm going to give you the best regimen that's out there with the higher rates of PCR. So disease burden definitely. And like you said, like I also look at the ER/PR status. In my mind, and also from the studies we have, especially NeoCARP, when you look at the subgroups, those patients with ER/PR negative disease and HER2 positive disease, they are exquisitely sensitive to even a little bit of chemo, because the HER2 drugs are the ones that are really making a difference there. So in that ER/PR negative HER2 positive group, then I'm comfortable giving like a taxane-based HP-like regimen. Again, as far as they have a little bit of on the lower side disease burden to see how they are going to respond. And I like your idea of like flipping the order, where you can maybe start with THP or really not losing anything there, and then assess their response and make a decision to go for TDXD or not. And again, I'll throw another provocative thing. We all love ctDNA, right? You cannot
just thinking about that.
Have any discussion without bringing that up. And in fact, recently a great study showed that even this, cycle 2 day 1 ctDNA drop by itself was such a strong prognostic factor. In fact, it was even predicting the long-term response better than achieving a PCR or not. So, again, I'm not sure if you're using ctDNA in your practice. I haven't started yet, but just wanted to see if you are doing it.
No, I think that's a great question. And in addition to the ctDNA, also the advanced imaging. There have been many studies looking at early PET response and prediction of path CR. So I think, ultimately what we would love to see is being able to utilize having studies showing us prospectively that, either clearance of ctDNA or seeing early metabolic responses with PET imaging would be fantastic to really help tailor what our first and second phase in the neoadjuvant setting would be. I haven't done that off of a clinical trial yet, but I would love to have a clinical trial where I could watch patients throughout the course, and we could all learn from that, so that we can really tailor to the individual patient.
Yeah, I'm really hoping that, a study like that would be designed to sort of, more of a response-tailored treatment approach in the neoadjuvant setting. In fact, as we discuss newer, even ctDNA, there are multiple companies coming up with newer assays, and, I'm trying to put the plug in, look for the neoadjuvant scenario, not just the surveillance scenario, because neoadjuvant, you can answer a lot of questions.
And really help you with that predictive value to path CR, which is what we sort of talked about at the beginning. Is, historically we have seen in many, many studies that pathologic complete response is a predictor for long-term outcome. The one place that's very challenging, and I don't have the answer to this yet, is the CNS recurrence rates. And so it'll be really important for us to be monitoring to see if we can determine whether or not certain strategies or either ctDNA or imaging or regimen will help decrease the rate of isolated CNS recurrence in the future, which unfortunately we do see in our patients with pathologic complete response. Very different protection than extracranial disease recurrence. So I'm hopeful to see that in the future as well.
Yeah, that's definitely an unmet need. And I know, DB11, DB05, they are sort of collecting all that data, like CNS recurrence rates. So that would be very interesting to see how much Enhertu making a difference, especially in the adjuvant setting, if it's, superior to TDM1, which we know doesn't really work that well in the CNS space.
Certainly.
Yeah. Also, one quick question about the approval. FDA approval, it's much broader than the trial inclusion criteria. Are you trying to adapt the FDA label, or are you trying to go by the study criteria? Any thoughts on that?
I think more globally, I've sort of thought about it as any T3 or greater, or any N1 or greater, T2 N1 or greater. So I think I've sort of adapted it more of larger tumor size or presence of lymph node positivity. I'd be curious how if you've done something similar.
Yeah, in my mind, I was thinking when I heard the study first, just to apply it to the exact study population. But I'm a little surprised to see that FDA sort of went and gave a little bit of a broader indication. But again, in the T2N0, the sort of the lowest end of that spectrum, I think I'm still going to be comfortable with a chemotherapy-based approach, and sort of reserve the TDXD, because again, that group was not represented in the trial, and I really don't know if they all need TDXD, but maybe that response-adapted design that you mentioned can also play in there.
Agreed, to make certain we aren't over-treating.
Right.
Exactly.
Yeah. So, Carey, I also wanted to, talk about the DB05, another very remarkable landmark study for us. And I just wanted to hear your thoughts. Maybe we can start with the study design and endpoints and what your thoughts are.
Sure. So just on the heels of the FDA approval, very exciting time for early stage HER2-positive breast cancer. Essentially, the DB05 study evaluated patients with high-risk residual disease. Historically, we had given TDM1 as per the Catherine data, which was randomized against trastuzumab, but in DB05, TDM1 was evaluated with TDXD as the comparator arm. And we saw a significant improvement to disease-free survival favoring the TDXD with an absolute benefit of close to 8%, which was really remarkable and very exciting to see. So in thinking about the inclusion criteria for those in DB05 versus the FDA approval, the FDA approval was a little broader. So really any residual disease, which was very akin to the Catherine study.
Right.
So really being able to have that option for patients moving forward with residual disease to decrease risk of recurrence.
Right. I think that's a super important study because once you have residual disease, we all know that those are the patients who are going to have much high risk for reoccurrence, especially metastatic disease, which is uncurable. So having a better option than TDM1 is certainly very important and practice changing. And not only that, we all noticed that from Catherine trial, even though the recurrences were reduced compared to Herceptin back then, but the CNS recurrences were not really any better with TDM1 compared to Herceptin. However, we all know that TDXD has such a impressive activity in the CNS space. So I'm really looking forward to seeing their CNS data, which I'm sure they are collecting and will be presented in future meetings. And if we can make a big difference there, because it's a sanctuary site, I'm sure you know better than anyone, how much these patients suffer with CNS disease. So I'm very excited for that factor as well.
Particularly as the data matures.
Right, right.
Yeah.
And we know that, it's those ER positive, HER2 positive patients, those are the ones who always have much higher chances of having residual disease. And I think the study represented more than 70% of patients with ER positive, HER2 positive disease. So again, glad to see that they all responded well to TDXD.
Absolutely. And I think that's when we think about the neoadjuvant space, we do see higher pathologic complete response for ER negative, HER2 positive. So I think the DB05 having an overrepresentation of ER positive, HER2 positive is very, very consistent with what we see in our clinical practice. Absolutely.
Yeah, yeah. In terms of, sequencing or giving radiation concurrently, because obviously these patients, most of them, they are all having high risk of disease. So most of them will be candidates for adjuvant radiation therapy. And I'm glad that the study team looked at both scenarios very carefully, giving it concurrently versus sequentially. And even today, there was a nice presentation looking into a very granular level, like what happened to those patients, what were the rates of ILD versus radiation pneumonitis. So what are your thoughts on that data and how is your center adapting this?
Yeah, I think the data today was really helpful as we're making these decisions in the clinic. And we as an institution have had conversations and looked back at the protocol. I think we've all been very comfortable to give TDM1 and adjuvant radiation.
Right.
But the question was, with the pneumonitis risk, how did we feel about the concurrent versus sequential? And I think from a recurrence perspective, we always want to start adjuvant therapy as early as possible. But what risk might we be incurring from an ILD perspective? So today, really, even just hours ago, we learned that the risk with concurrent radiation was very similar for ILD. The other thing that was very interesting was really differentiating the radiation pneumonitis, which would really be in the radiation port, compared to diffuse pneumonitis, which we usually see with drug toxicity. So really working closely, either with your pulmonary colleagues, if there's any question. I know we pull on the expertise of our pulmonary colleagues quite frequently at our academic center, which has been very helpful as we're making decisions. But I found that data to be quite reassuring reassuring. I'll feel much more comfortable to offer the patient concurrent therapy, particularly a patient who has high burden residual disease, where we're really worried about the risk of metastatic disease. Right. And then also kind of thinking about the patient again. Our real world population of patients many times is not completely represented in a clinical trial population, where underlying pulmonary disease may be higher in the general population, really figuring out which patients might be at higher risk for either radiation therapy pneumonitis or ILD. Was also reassuring. They looked at renal function, which has also been a predictor of ILD, so kind of taking that into consideration as well.
Right. Right. Yeah. No, those are all really valid points to, especially when we start implementing, we're going to see a very broader population than, the population that was represented in the trial. And also you brought a very important point that we have to clearly distinguish radiation pneumonitis from ILD, because the way you hold the drug, that you treat the pneumonitis, and when can you resume, it's very different between the two. So if we don't distinguish the differences, we may be taking Enhertu too early for a patient. So I think it's important to also understand the nuances, and thankfully the presentation today was very helpful, I thought.
Absolutely, and it's really nice in the presentation. They really break down grade 1 interstitial lung disease versus grade 1 radiation pneumonitis. Of course, in the setting of grade 1 interstitial lung disease, you can hold therapy, treat with steroids for better part of 3 to 4 weeks, and then re-challenge with TDXD. In the grade 2, in the ILD arm, if there's grade 2 symptomatic ILD, then we are no longer re-challenging with TDXD. But if it's grade 2 pneumonitis, you can. So I think that's really interesting. And I also think it's going to be very, when we do get to a place where we've treated more and more patients with neoadjuvant and adjuvant TDXD, ensuring that how this is categorized is very clear, so that if they do recur with metastatic disease, we still have the option of TDXD if they did not have grade 2 ILD from the drug. Right. And that's going to be really tricky. And I think we're going to need to, work within our groups to be able to differentiate this with our radiation oncologist, and also bring in our pulmonary colleagues as needed.
Yeah, this is going to be a true multidisciplinary situation, right? Like, it's a scenario where we need the expertise from everyone, even the radiologists, I think, trying to tease out and be more clear about where do you see the ground glass opacities, be specific about the location so we can make those right decisions for our patients. So I think we are all going to learn so much, as we start treating these patients and educate our colleagues about these nuances.
Absolutely. And having, high suspicion. Exactly. Right, and making certain that we're identifying, and I think this is where being able to monitor, particularly in the adjuvant setting, CT chest, non-contrasted CT chest, ILD protocols regularly during the adjuvant phase is going to be really critical.
Yeah. I think that's why, again, once we start to use this more broadly, having maybe an institutionalized protocol to follow may be much easier, like how we do echo every 3 months. It's built into our treatment plan. So even our nurses, they will not release the chemo, even if we forgot, or our APPs forgot to order the echocardiogram, they make sure that it's there before they release the Herceptin. So I think the same way I'm thinking, to implement something like that, maybe add the CT into the treatment protocol. That way it's there and we are all thinking about it proactively and not missing that
Absolutely.
milestone.
It was also interesting in the way that they ran the protocol for patients who did the sequential. They recommended a baseline CT scan after radiation, which I thought was really interesting, because what if there were changes in the lungs post-radiation that we weren't aware of, and then it gets attributed to TDXD down the road. So having that baseline, and if it's sequential, if the choice is sequential, getting a new baseline, and then having, every 6 weeks during therapy. And I love the idea of having the beacon build, because like you said, there's so many different moving parts. We'd hate for that to get missed. Yeah, it's a great point to standardize.
Also, because many times when the patient is in the surveillance, in the adjuvant setting, they are maybe seeing our APPs, our advanced practitioners, and they may not be seeing us with each cycle. So I think, again, educating our own team, our nurses and our APPs is also very crucial now that we are going to start implement this.
Absolutely, absolutely.
Yeah. So I think, another challenging scenario that we are all facing right now, because we have T-DXd that can be used in the neoadjuvant setting, but also can be used in the residual disease setting. However, if a patient is getting starting with the DB11 approach and they're getting T-DXd first, but unfortunately they are not getting a complete response and they have residual disease, how are you planning to tackle that scenario in the post-neoadjuvant setting?
This is one of the most challenging questions, moving from the neoadjuvant to the adjuvant phase. And, I can consider several different scenarios here. So a patient who has primary resistance, where they are presenting to surgery with relatively high burden, residual disease. I think that's more rare, thankfully. It's really going to be more like 1 in 5 patients. But in that case, considering bringing in a non-cross resistant or a cross resistant mechanism of action. You wouldn't want to go from the same mechanism of action to the same mechanism of action. And that's where I could envision bringing TDM1 in. We're all awaiting the Compass RD study, which is going to incorporate tucatinib with TDM1 to see if that might benefit patients greater than TDM1 alone. So you could envision in those patients where you really just aren't getting a good response to neoadjuvant therapy with TDXD, that giving adjuvant TDXD might not be the right thing for that patient. Another scenario may be where you get a near path CR or maybe an RCB1, and you're wondering maybe the patient just needed a little more TDXD, like you've had this really dramatic response. And so perhaps that might be a patient where giving the adjuvant TDXD may be just enough to be able to get them to best response, even in the adjuvant setting where we can't monitor it like we do in the neoadjuvant setting.
Yeah, no. Again, I 100% agree, and that's sort of the pathway I'm thinking in my mind as well. Like you mentioned, TDM1 has an emtansine-based payload, whereas TDXD has a topo1 payload. So having a different payload, if patient was not responding at all to TDXD, would make sense. Also, we know from the DB03 data, right? Those patients who got TDXD, when they progressed, some of them did go on to TDM1, and they did see response there. So I think we have some data, at least from the metastatic setting, we can extrapolate to justify the use of TDM1 post TDXD until Compass RD comes, because I'm really looking forward to that study. I hope it's a positive study. Plus, of course, the tucatinib's activity in the brain is another one we are all looking forward to seeing happening. So with that study, we may have another option or combination option if it's positive.
That's a great point you bring up about the CNS recurrences, because I think we were all surprised by Catherine. I think we all expected to see lower CNS recurrences in the TDM1 arm, and in fact they were very similar. So I think it'll be very interesting to see what the addition of a brain permeable tyrosine kinase inhibitor in that space does to decrease risk of CNS recurrence.
So let's also talk about another practical struggle that we may face, because now we are, instead of giving TDM1 for 1 year, which we know is usually, relatively pretty well tolerated. Patients may have a little bit of neuropathy. We have to keep an eye on the liver function studies, platelets, but overall it's a pretty well tolerated regimen for a year. But now we are talking about a stronger ADC with more toxicity for a whole year, especially in a curative setting where patients can't, they can't finish it and move on with their lives, but then we are adding more toxicity there. Like, how are you counseling your patients about the side effects?
No, I think it's a great discussion, and really helping patients understand what their life will look like during that period of time. I know we've both given TDXD, we've both given TDM1, and TDXD in some patients is very well tolerated. However, in some patients, the fatigue and the nausea can be pretty debilitating. I think we work really hard, and since we started giving TDXD, the way that we manage nausea is much more aggressive.
Right.
And so I am seeing in my practice more globally less nausea in the metastatic setting, and of course we would extrapolate that to our adjuvant care as well. The fatigue can be really problematic, and for a young, healthy patient who needs to get back to her life after surgery, that can be, in some cases, a non-starter. Right. And so what I would love to see is what happens, and we do frequently dose reduce in the metastatic setting. In the adjuvant setting, we're a little less flexible with dose reduction because we really want to maximize dose intensity. But in order to get through and have adherence for the full 14 cycles, we may need to dose reduce. And so having some data to help us understand how dose intensity might impact outcome in the future would be really helpful when we're guiding patients. We don't want them to be miserable for 14 cycles. So I think, really working hard on their antiemetic regimen, really starting with triple therapy. It used to be we started with doublet, and now we go up to triplet therapy, and then utilizing dose reduction if the fatigue is really impacting quality of life in a very detrimental way.
Right, right. I think the PRO data would help us understand how those patients did on the trials, but still in the real world, things can be very different than what we see on trials. So I think as providers, like you said, counseling them, setting the right expectations, especially hair loss is a big concern. They probably lost their hair, and then during the surgery and recovery, maybe it's coming back. And now we are saying, you're going to lose it again. Again, it's like a roller coaster, right, for them up and down. So I think, setting the right expectations and counseling them and giving as much as support that we can from the team would be crucial.
And in some cases, they may not have received TDXD in the neoadjuvant setting and were able to cold cap without alopecia. So then really being transparent about the fact that most patients who receive TDXD are going to experience alopecia. And my understanding, although we have not implemented cold caps in this setting, is that the capacity for retaining hair in a meaningful way is not prevented with cold capping with TDXD based on the mechanism of action.
Right, right. Yeah, I know there are studies ongoing to systematically look at the prevention rates with these novel ADCs, but until then, I really don't give any strong promises about what's the percentage of keeping on to their hair, what's the success rate. We don't know. So I'm also, again, like you said, very careful about if they really want to invest on that. I have a low threshold to. Yeah.
Absolutely. And I think in the studies, it usually says 40% alopecia, but I would say in the real world, we're seeing much higher rates than that.
Yeah. So Carey, again, the FDA approval is for any residual disease, but the study actually included patients with much higher risk. So in which scenarios do you think, we may not need TDXD and can get away with TDM1?
I think your point is really well taken. I mean, I think there is a difference in terms of the amount of residual disease or the risk of the patient's TNM stage up front in terms of who was eligible for TDXD. I do wonder about those with RCB1, lymph node negative disease, as to whether or not TDXD is absolutely necessary. I think it's a place we really need to study so that and there may be a day when TDM1 is combined with other agents. Right. And so which patient may benefit best from TDXD as an ADC or a microtubule inhibitor ADC with fewer side effects. So I think that's really an outstanding question that I'm hopeful we get some data for soon.
Right. And, I was also thinking for those patients who did not fit the criteria for DB05, but they still had residual disease, it would be, again, I envision seeing a study where maybe they're doing 6 months of TDXD followed by Herceptin, because we know TDXD looks like better than TDM1 in multiple different scenarios, but I don't know if you need that whole year. So I was thinking in my mind, if a study like that with a maybe shorter duration in those lower risk, but still having residual disease, could answer or could come up with a similar outcome. But that's, again, completely something I'm thinking in my mind.
It's a great question. I mean, I think we have a long-standing history of duration of trastuzumab, even with the short HER study, and which patients may only need 6 months versus 12 months. So you could envision, could we really individualize to that patient who has lower burden, and this is where RCV could also be very helpful, where they only need 6 months as opposed to 12 months. So I think that would be really interesting to study prospectively.
Yeah. Yeah.
Or retrospectively.
Yeah, that's true. Because patients will be discontinuing. You know, a lot of them may be discontinuing at some point and going back and seeing what were their outcomes when they discontinued halfway or something like that.
Sure.
Yeah.
Sure.
Yeah. No, that's a good point. Another difficult question I'm going to throw at you, Carey. So, but a very practical question. So, you know, patients who are early stage patients who are getting TDXD in the neoadjuvant or adjuvant setting, but then, God forbid, they progress into metastatic disease. How are you thinking about handling their first-line treatment, because we do have the approval of TDXD plus pertuzumab based on the DB05 data, 09 data, or based on the DB09 data as the first-line treatment. But now that some of these patients are going to be exposed to TDXD already in the early stage setting, do you have an algorithm how to, design their first-line treatment? Is there a disease-free interval that is important for you to go back to TDXD versus not use TDXD and go to the next line?
That's a great question. And I think we do have a historical perspective where, I can remember going from taxane to taxane. Now we have adjuvant CDK to first-line metastatic CDK. And I think historically I would very much follow what we've done in the past. And, it's a wonderful problem to have because we're moving these therapies from the metastatic setting into the curative intent space. But unfortunately, we won't cure 100% of our patients. We'd love to. But I do think that 1 year disease-free interval will be important to me. I think if a patient progresses very quickly within 3 to 6 months, I'm going to be thinking about going to a different mechanism of action in the first-line metastatic setting. But if a patient has had more than 12 months disease-free interval, I would very likely go back to TDXD until we have more data to guide us otherwise.
Yeah, no, that makes sense. I think those patients who are progressing very quickly, tucatinib-based regimen, Hertuclimb is another regimen that we can use. These patients have not seen any TKIs so far, so I think that's what I would be doing too. But it's an unmet need, though. When patients progress through TDXD, the disease becomes a biologically very aggressive and very hard to control with anything that comes after, at least based on my anecdotal experiences. So I feel like we need even much robust, maybe bispecifics or a novel class of drugs to answer that question. But it can be a problematic group of patients that we are going to see much more and more as we start moving these agents early on.
No, I think your point is really well taken. And I think the other big question is, what are the resistance mechanisms?
Right, exactly.
And so really being able to understand the biology, is it that we're seeing emergence of ERBB2 mutations? Right. And then that might lead us, many of the next generation HER2 targeted TKIs are also targeting the HER2 mutation. So perhaps, as they start to develop, maybe that's the direction we go in. But I think it'll be really important for us to understand what is driving that resistance, because you're right, it's a very aggressive phenotype. And so having a little more information about what the resistance mechanisms are at a molecular level to be able to match their therapy is going to be very helpful, particularly in the advent of the bispecifics and, the tyrosine kinase inhibitors that do target the ERBB2 mutation.
It was such a wonderful discussion. And, we both were able to share a lot of our practical tips and with each other and with the audience. So I really appreciate you being here. And thank you so much for having us here.